Good morning, everyone. We are Group 6 and we are here to discuss multidisciplinary treatment of non-syndromic oligodontia. The introduction of the article highlights the condition called oligodontia, which refers to the congenital absence of six or more permanent teeth, excluding the wisdom teeth. It is reported to have a prevalence of 0.3%, and it occurs more frequently in females. The absence of teeth, especially in the front region, can lead to aesthetic, functional, and psychological issues. For the patient demographics, her name was Asia Yilmaz. Date of birth was March 19, 1995. Age is 17 years old. For the patient demographics, her name was Asia Yilmaz. Date of The chief complaint was there is a large gap between my teeth and the gap is increasing. I often get bullied because when I speak, I unintentionally spray saliva. For the history, we have two. First is the family history. The patient's brother was also diagnosed with oligodontia. Second is the medical history. She underwent a surgical operation for an imperforate hymen.
A female patient, 17 years of age, was referred to Istanbul University, Faculty of Dentistry, Department of Removable Prosthodontic for unpleasant mouth and replacement of missing teeth. The article focuses on the case of a 17-year-old patient who has non-syndromic oligodontia, meaning it is not associated with any other medical condition. The patient is missing a total of 11 permanent teeth. Genetic counseling revealed that the condition is linked to an autosomal recessive genetic pattern. Extraoral frontal and power examination revealed a facial asymmetry and a mild decrease in lower facial height along with a flat profile. The nasolabial angle was within normal limits, and the lower lip was full and slightly protruded relative to the upper lip at closure. A deep mentolabial sulcus was present, and increased activity of the mentalis muscle was visible in the skin overlying the chin upon lip closure. For intraoral examination, it is revealed that missing of 11 permanent teeth were not due to extraction and were absent since childhood. The missing teeth were maxillary lateral incisors, maxillary second premolars, mandibular central incisors, mandibular right and left first and second premolars, and right second molar with bilateral crossbite of the maxillary first molars, which were restored previously but presented with secondary caries. The third molars were clinically absent. The maxillary deciduous second molars, mandibular left deciduous second molar, and mandibular deciduous central incisors were present in dental arches. For diagnostic record, the first figure showed missing maxillary lateral incisors, maxillary second premolars, mandibular central incisors, right second molar, and all third molars. Maxillary first premolars were marked conical shape and mesodistal diameters of the teeth crowns were reduced. Orthopantogram also revealed that maxillary first molars were endodontically treated.
Genetic counseling and familial evaluation play a crucial role in understanding the inheritance pattern of the condition. By examining the patient's genetic history and family members, healthcare professionals can gain valuable insights into the underlying genetic factors contributing to the condition, such as a non-syndromic autosomal recessive link oligodontia. This information is valuable in determining the most appropriate treatment approach, and it can also help in providing genetic counseling to the patient and their family members. Upon genetic counseling, the patient's findings were as follows. The patient is a second child of five from a non consanguineous marriage. Her family history revealed that her brother was also diagnosed with oligodontia. For her medical history, she underwent a surgical operation for imperforate hymen. Her neuromotor were normal with no specific findings suggesting any syndrome. and her ophthalmic examination and skeletal X-ray indicated normal findings. It is noted that oligodontia is a frequent finding in ectodermal dysplasia. Thus, this syndrome was evaluated in differential diagnosis. But sweating, patient's nails and skin appeared normal. Thus, ectodermal dysplasia was excluded. Oligodontia might be autosomal recessive link because of the familiar missing teeth in the patient's brother. The treatment planning described in the article involves a two-phase approach to address the complex dental condition. The first phase is the pre-prosthetic orthodontic therapy. The objectives of this phase are to create orthodontic space for proper prosthetic restoration of the missing teeth and to correct intermaxillary relations. Techniques used in this phase include the use of a pre-adjusted edgewise appliance, which is a 0.022-inch Roth prescription, Nitai and SS arch wires, open coil springs, and elastic chains. The results achieved in this phase include the closure of the maxillary midline diastema, opening of the necessary lateral incisor space, and improvement in lip position. The second phase is the prosthetic restoration. The objectives of this phase are to provide both function and aesthetics through the replacement of the missing teeth. Restorations used in this phase are full mouth porcelain fused to metal crowns and bridges. The article mentions reasoning for increasing the vertical dimension of occlusion by 2 mm. This is done to facilitate the prosthetic restoration process and to enhance facial aesthetics in the anterior dentition. Significance of multidisciplinary teamwork involving an orthodontist and a prosthodontist, and in some cases, a maxillofacial surgeon may also be required. Consideration of patient age, existing teeth condition, occlusion, and interocclusal rest space in the treatment planning process. Importance of genetic counseling and familial evaluation in understanding the condition's inheritance pattern. Overall, the collaboration between different specialists and the thorough consideration of various factors, including genetic aspects, ensures a well-rounded and tailored treatment plan for the patient's oligodontia condition.
Phase 1 is orthodontic therapy. Initiation of orthodontic therapy. Orthodontic treatment began after completing oral prophylaxis. A pre-adjusted edgewise appliance or 0.022 Roth prescription was placed on the upper and lower permanent teeth to commence the orthodontic intervention. Second, initial alignment. The initial alignment was involved using a 0.014 Nitai arc wire to guide the teeth into proper alignment. Number 3. Space consolidation. Spaces between teeth were gradually closed using a 0.017 times 0.025 stainless steel arc wire. Open coil springs and elastic chains were employed to facilitate the consolidation process. Number 4. Retention and stability. After achieving the desired alignment and space closure, a rigid 0.019 times 0.025 stainless steel arc wire was installed to retain the achieved results and ensure stability. Number 5. Midline diastema closure and lateral incisor space. Successful closure of the midline diastema or gap between central incisors in the maxillary arc. Necessary space was opened for the prosthetic restoration of the missing maxillary lateral incisor. Number 6. Improvement in lip position. Orthodontic therapy contributed to an improved lip position, enhancing facial aesthetics. Number 7. Retention phase. The achieved results were retained for a period of 3 months using a nighttime wearing of maxillary and mandibular Essex retainers. Essex retainers are clear aligners designed to maintain teeth in their corrected positions. After retention phase, prosthetic therapy was initiated. Mandibular deciduous incisors and deciduous second molars were extracted prior to initiation of prosthetic therapy. Phase 2 prosthetic therapy. Number 1. Extraction of deciduous teeth. Before starting the prosthetic therapy, the mandibular deciduous incisors and deciduous second molars were extracted to make way for the fixed restorations. Number 2. Surgical crown lengthening. An endodontically treated maxillary left first molar required surgical crown lengthening on the palatal side due to insufficient crown height. After 3 weeks of gingival healing, a cast nickel chrome alloy post-core restoration was fabricated to prepare the tooth for the final restoration. Number 3. Preparation of missing teeth. Maxillary canines, central incisors, second premolars and molars, mandibular canines and lateral incisors and molars were prepared for the fixed restorations. Number 4. Impressions and vertical dimension of occlusion or VDO adjustment. Maxillary and mandibular impressions were taken using a putty wash technique with a condensation type polyvinyl siloxane silicone impression material. Casts were mounted on an articulator with a 2 mm increase in VDO to accommodate the fixed prosthetic restoration and improve facial aesthetics on the anterior dentition. Number 5. Interocclusal record. The mandibular cast was mounted with a silicone-based interocclusal record material using a centric relation record obtained by bilateral manipulation. Number 6. Provisional restorations. Full mouth provisional restorations were fabricated at the newly established OVD and fitted in the mouth. Provisional restorations were maintained intraorally for 2 months to assess their function, aesthetics, and speech improvement. Number 7. Final restorations. Maxillary and mandibular impressions were made with a putty wash impression technique using addition type polyvinyl siloxane silicone impression material. Full mouth porcelain fused to metal restoration. Number 8. Canine guidance development. Canine guidance was established to reduce lateral forces on the posterior dentition, ensuring proper occlusal function. Number 9. Provisional cementing and evaluation. The restoration were provisionally cemented using Provicol. The patient was examined over an additional week to ensure stability and functionality. Facial soft tissue appearance remained largely unchanged following the VDO increase. Final cementation. After confirming no pathological signs or symptoms in the orofacial structures, the restorations were permanently cemented using a polycarboxylated cement. Result: orthodontic therapy outcomes. The orthodontic therapy led to the successful closure of the maxillary midline diastema, which is the gap between the front teeth. Additionally, the treatment opened up the lateral incisor space, creating enough room for proper prosthetic restoration of the missing teeth. As a result of the orthodontic treatment, the patient experienced an improved lip position and facial profile, enhancing their overall appearance. Prosthetic therapy results. The prosthetic therapy using full-mouth porcelain fused to metal restorations was successful in providing functional and aesthetic rehabilitation for the patient. The restorations replaced the missing teeth, enabling the patient to chew, speak, and smile with improved functionality and appearance. Importantly, the article notes that the management of 11 permanent teeth was achieved without the need for dental implants. This suggests that the combination of orthodontic and prosthetic approaches was effective in addressing the complex dental condition without resorting to implant-based solutions. Overall, the combination of orthodontic therapy to create the necessary space and correct dental alignment, along with prosthetic therapy using porcelain fused to metal restorations, resulted in favorable outcomes. The patient experienced both functional and aesthetic improvements, and the comprehensive treatment plan successfully addressed the challenges posed by the non-syndromic oligodontia condition, allowing for the management of the missing teeth without relying on dental implants.
In etiology, the pathogens of congenital tooth missing is thought to be prior to final prosthetic therapy, pre-prosthetic orthodontic. So challenges in prosthetic treatment, small and conical. So for the conclusion, the implication of missing teeth are diverse. Successful treatment plan for non-syndromic oligodontia involves